So today we are starting a new chapter, that is the uterine tumors. So the tumors that are present in the uterus are mainly divided into two main types. The first one is the benign tumor and second one is the malignant tumors. So the benign tumors of the uterus include endometrial polyps and the uterine fibroids. First one is the endometrial polyps. So polyps are the abnormal focal outgrowth of the endometrial tissue, and endometrial polyps are usually benign in nature, but in 1% of the cases they may be malignant. And the risk factors that may lead to the endometrial polyps include obese women, late menopause, hormone replacement therapy, and the tamoxifen. Tamoxifen usually had inhibitory effect on the breast tissue, but it may causes a stimulatory effect on the endometrium and causes growth and hyperplasia of the endometrium and may causes endometrial polyp. Next is the presentation of the patient having endometrial polyp. So the endometrial polyp may causes heavy menstrual bleed, intermenstrual bleed, postmenopausal bleed, lower abdominal pain, and 10 to 20% of the women it may causes abnormal uterine bleeding, but in 10% of the cases these polyps may causes infertility. And the polyps are diagnosed by transvaginal ultrasound, outpatient hysteroscopy, and we also do saline infusion sonography, and all of these investigations are used to diagnose the endometrial polyp. And the treatment of endometrial polyp involves the surgical removal of the polyp, that is known as polypectomy. Second and most common benign tumor of the endometrium are uterine fibroids, and these fibroids usually arises from the smooth muscle cells of the myometrium, and the fibroids are also known as uterine leiomyomas, which are the benign tumors that arises from the smooth muscle cells of the myometrium, and they are very common and usually present in around 40% of the women. And the cells within an individual fibroid or myoma are monoclonal in origin, but the cells from different fibroids within the same uterus are independent in origin. And the fibroids are estrogen dependent tumor, means that the fibroid increases in size when the estrogen level are high, that occur in pregnancy. Similarly, the size of the fibroid decreases when the estrogen level is low, such as that occur in menopause. So after menopause, the size of fibroid decreases because of decrease in the estrogen level. The risk factors for the fibroid include nulliparous women, obese women, those having a family history, and the women belong to the African origin. Next one is the types of the fibroids. So the fibroids include intramural, which are located within the myometrium, and they are the most common type of fibroid. Second one is the submucosal fibroid, and more than 50% of the submucosal fibroid project into the endometrial cavity. And fibroids may be subserosal, and more than 50% of subserosal fibroids they project are extend outside the uterine contour. And the fibroid may be pedunculated, which are mobile, and they are more prone to the torsion. And similarly, the fibers may be cervical, but the cervical fibers are uncommon and they may be interligamentary. So the types of fibroid include pedunculated, which are mobile and more prone to the torsion. Similarly, the fibers which are present inside the myometrium are intramural. They may be submucosal, which causes infertility, and similarly, the fibers may be subserosal, they may be interligamentary, or they may be cervical. So the submucosal fibroids they can cause distortion of the endometrium and causes infertility. So the removal of submucosal fibroid can increases the chances of fertility, and therefore they increases the chances to conceive through assisted reproductive techniques. And removal of other types of fibroid are less effective, and they are associated with increasing risk of bleeding. So the submucosal fibroids are associated with increasing risk of infertility, and the removal of these fibroids can increase the chances of fertility. Next is the clinical presentation of a patient having fibroid. So the patient of fibroid may be asymptomatic initially. The fibroid may cause abnormal uterine bleeding. They may cause dysmenorrhea, which are painful menstruation. It may cause infertility. It may cause recurrent loss of pregnancies or miscarriages. Similarly, the fibroid causes pressure due to pressure on the bladder. The fibroid causes urinary frequency and urgency. Similarly, fibroids may cause constipation due to pressure on the rectum. And the signs in a patient having fibroid include anemia, which occur due to the excessive blood loss. Similarly, the fibroid causes asymmetrical enlargement of the uterus, and the uterus is usually firm and non-tender in case of fibroid. And the uterus may be tender if there is degeneration of the fibroid occur. And on per vaginal examination, the fibroid usually moves with the movement of the cervix. And the differential diagnosis of a fibroid may be pregnancy, ovarian tumor, leiomyosarcoma, which is a malignant carcinoma of the myometrium, adenomyosis, and the rudimentary horn of the uterus. All of these are the differential diagnosis of the fibroid. And the complication of fibroids include effects of fibroids on the pregnancy. So the fibroids may cause small presentation, they may cause obstruction of the labor, obstructed labor, they may cause prolonged labor, they also increases the risk of miscarriages. Similarly, they also cause cervical dystocia, increasing risk of preterm labor, and the fibroids also interfere with the separation of the placental tissue. So therefore, they increases the chances of the postpartum hemorrhages. And the general complications of fibroid include infection, torsion, and the pedunculated fibroids are more prone to the torsion, and there may be degeneration occur in the fibroid. And the degeneration occur when the fibroid outgoes at blood supply, means that there is a decrease in the blood supply to the fibroids. And the degeneration are divided mainly into three main types. First one is the hyaline degeneration. So hyaline degeneration occur when the fibroids gradually outgoes its blood supply, and it causes asymptomatic softening and the liquefaction of the fibroid. So in hyaline degeneration, there is a gradual decrease in blood supply, and there is a softening and liquefaction of the fibroid occur. Second one is the wet degeneration. So in wet degeneration, there is acute decrease in the blood supply, and it is sudden in onset, and it usually occur in pregnancy. And wet degeneration, there are hemorrhages occur and necrosis occur within the fibroid. Third one is the cystic degeneration. So in cystic degeneration, there is a necrosis occur in the center of the fibroid, along with the resultant central cystic changes. And there may be malignant sarcomatous transformation occur also in case of cystic degeneration, but the chances are less than 1%. So the types of degeneration include hyaline degeneration, wet degeneration, and the cystic degeneration. Next one is the investigations that are done in a patient of fibroid. So the baseline investigation include complete blood count, in which we check the hemoglobin level. Similarly, we can also do the urine RE, and the specific investigations for fibroid include transvaginal ultrasound. Transvaginal ultrasound is done to detect the submucosal fibroid in the small intramural fibroid, and transabdominal ultrasound is done to detect the subserosal and larger intramural fibroid. Similarly, we also do saline injection sonography, and the saline injection sonography is done to detect the submucosal fibroid and the endometrial polyp. Similarly, we can also do the hysteroscopy that involve the direct visualization of the endometrial cavity, and through hysteroscopy we can detect the submucosal fibroid and also the endometrial polyp. And the hysteroscopy also provide a roadmap for the future hysteroscopic surgical resection of the fibroid. Similarly, we can also do the MRI. The MRI is best for detecting the exact morphology and the location of the fibroid, because the MRI tells us about the morphology of the fibroid and the location of the fibroid, and it is indicated prior to the uterine artery embolization, and also to monitor the response to the treatment. Next one is the management of a fibroid patient. So if a patient is asymptomatic, we simply observe the patient. But if the fibroids are symptomatic, then we can do a medical treatment of patient, and similarly we can also do surgical treatment. So the medical treatment options include tranexamic acid and the NSAIDs. So these drugs are usually non-hormonal and non-contraceptive, and they are fertility preserving agent, and they are usually helpful in symptomatic relief. And these drugs are usually ineffective if the fibroids are submucosal, the uterus is larger, that is more than 12-week size. So the NSAIDs are used for the control of pain and dysmenorrhea, and the tranexamic acid is used to control bleeding. Next one is the GnRH analog. The GnRH analogs include leuprolide and gosavalin, and they are the only effective medical treatment, and they produces menopausal state by decreasing the ovarian estrogen secretion. And GnRH analogs are given before the surgery because they causes the shrinkage or decrease in the size of the fibroid. And the GnRH analog are not well tolerated because they causes the menopausal symptoms, and they also increases the risk of osteoporosis. And when the GnRH analogs are stopped, the ovarian function and return, and the fibroid regrows. So it is not a proper therapy. The other medical treatment option include selective progesterone receptor modulators. So these drugs, they act selectively on the progesterone receptor. And the most common selective progesterone receptor is ulipristal acetate, and it is given orally, and it is effective as the GnRH analog because they causes the reduction or shrinkage in the size of the fibroid, and they control the symptoms of the heavy menstrual bleeding. But unlike GnRH analog, they do not causes the menopausal state. So they are usually PrEPA agents as compared to the GnRH analogs. And one is the surgical management of a fibroid patient. So the surgical options include myomectomy, hysterectomy, and the uterine artery embolization. Myomectomy involves the surgical resection or surgical removal of the fibroids, and this procedure usually preserves the fertility. So it is usually done in a younger patient who had symptomatic fibroid and they failed to respond to the medical treatment, and the woman who want to conserve her uterus and the family is not complete, and the infertility is the cause of fibroid. In such patient, we do myomectomy. Hysterectomy involves the surgical removal of the uterus, and this procedure does not preserve the fertility, and therefore it is usually done in older patient whose family is complete and their age is more than 40 and they have multiple fibroids. Third one is the uterine artery embolization. This procedure is performed by interventional radiologist, and it involves the embolization of the uterine artery with the resultant decrease in blood supply toward the fibroid, and there is infection and the degeneration of the fibroids occur because of decrease in the blood supply. And uterine artery embolization involve decrease in about 50% of the fibroid volume, and this procedure preserve the fertility. So it is equivalent to similar to a myomectomy and controlling the fibroid related symptoms like heavy menstrual bleed and the pressure symptom. Next one is the Asherman syndrome. In Asherman syndrome, there are fibrosis and adhesions inside the uterus, and it is also known as the uterine synecdoche or the intrauterine adhesion. And this syndrome is characterized by the presence of adhesions and fibrosis within the uterine cavity. And the risk factor for the Asherman syndrome include recurrent uterine infection, and that is the endometritis, vigorous uterine curettage, which is the most common cause of Asherman syndrome. Similarly, it may occur in case of tuberculosis of the genital tract and schistosomiasis. And the present representation of patients with Asherman syndrome include secondary menstrual irregularities, amenorrheas, repeated miscarriages, and the infertility. And the treatment of Asherman syndrome include hysteroscopic adhenolysis that involve the lysis of the intrauterine adhesion.